in a changing landscape of educational reform, and actually the way it works for me, because everything moves so quickly, it's probably more a changing seascape of educational reform. So, I think we have to start by defining what's the problem. And the problem for me is that we're not getting enough people into the training pathway to be able to supply you with the workforce that you need. We've got a predicted retirement bulge, so particularly in general practice and psychiatry, you have people sort of 55 plus. They're the very people who provide the expertise and the clinical leadership. And then we've got perverse incentives. I'm a GP by background, full pension pot. If I wasn't doing postgraduate dean, why would I stay in general practice? The answer is because I like it and I have a lot to offer, but my pension and the treasury, it's not cost effective for me to stay. At the moment, the NHS is perceived, particularly by the young generation, the school leavers, as a toxic place to be, to work and to train, and we have to change that perception. So, that's the problem as I see it, and for me as the person who has to keep that training pathway going and supplying the workforce. So what I'm going to do is give you a whistle-stop tour of the challenges, the context and the background, and a little bit about how curricula across the workforce are changing. And then, because I'm from HEE, I absolutely have to tell you about the Workforce Transformation Star. So, I'm not going to drone through these one by one, but these have been the significant drivers for change for us in medical education and workforce over the last 15 years. And the ones that are highlighted are the ones that impact most on me. And when I say me, I mean my office delivering the training and workforce pathways. This is Health Education England's mission statement, and I am going to read it to you. To support the delivery of excellent healthcare and improvement to the patients and public of England by ensuring that the workforce of today and tomorrow has the right numbers, right skills, values and behaviours, right time, right place. It sounds like motherhood and apple pie, but actually, if you're designing a workforce, that's where you need to start from first principles. I have used this slide in interviews for the last 10 years, but actually it's very, very relevant. And what I find frustrating at the moment is that particularly around workforce planning, is people are very reactive in their approach. They do not go back to first principles. So for example, Jeremy Hunt says we need 5,000 more GPs. They throw money at it without thinking about it, what do we actually need? So we will never have 5,000 new GPs. We cannot grow that many in sufficient time. But actually, what you want is a rapid access and easily accessible to primary healthcare services at an appropriate time and appropriate place. It's not about throwing more GPs. It's about looking at the whole system. So you come at this from an evidence-based approach, and the first thing you absolutely do, like any research approach, is to define what the question, what the problem is, and then you can begin to test the evidence against that. So the first thing we have to do is what is fitness for purpose? Because there is no point in you being in medical schools and developing programs to develop the healthcare workforce of the future if you don't know what that fitness for purpose looks like. And that's a big problem because it changes faster than you can change the curriculum, and there's a time lag there, and it changes with the political wind. So that's the first given. Second one is you absolutely have to align undergraduate and postgraduate education. And this is not just about doctors, this is about everybody all the way through, and particularly around the developing the multi-professional agenda and working and training and learning together right from the beginning of your educational experience. There's no point in doing it in postgrad if our undergrads through the system come at it like a rabbit in headlights because they've never worked that way before. Your health workforce has to meet the needs of the local population. No point in training a whole load of little fingerologists if what you need across the northwest of England, particularly Lancashire and Cumbria, are mental health nurses, psychiatrists, mental health teams, and general practitioners. And I don't just mean doctors, I mean the whole of the primary care workforce. Right numbers, right time, right place, that's a given. And having got them there, we have to keep them there. And that's about professional development. You know, there's no point in getting a high quality physician's associate, advanced care practitioner, your doctor who's going on to specialist training, if you actually then don't support them to stay in that locality. And for me, inevitably, it's not just cost effective and value for money, it's doing more for less. And this is the problem. This is taken by my husband, the walk across Morecambe Bay Sands, the Cross Bay Walk. And I just thought that simply sums up my problem because it is shifting sands. And particularly this bit here. Because all the expansion of new medical school places, people starting this summer will not be available as a new doctor going into foundation until 2023. And if you're heading for a specialist consultant, probably 2031 is before you're ready in the workforce at that level. If you're heading for general practice, it's a bit better, it's 2027, which comes back to my other point. We cannot grow the workforce to supply the demand at the moment. We have to think of another way of doing it. So, 5-year forward view is the challenge for me at the moment. That was about what our workforce plan is, looking over the next 5 years to supply a fit-for-purpose workforce aligned to patient needs. And it described these 3 gaps: the health and well-being gap, the care and quality gap, and the funding and efficiency gap. And what that means: health and well-being inequalities, care, that's where in the organisations where that care is delivered, and funding and efficiency is workforce. And the problem with 5-year forward view, good document, very much focused about prevention and developing those areas of the team. We're 3.5 years through. We have to deliver this by 2020, and actually we're way past the curve for doing that. What was useful about it is it identified those areas in the workforce that we intuitively knew were the needs. So it's cancer, mental health, the urgent and emergency care pathway, and maternity and primary care. So just to set it into context, this is the northwest of England, this is my patch, the whole of the northwest of England, 6.5 million at-risk population, a healthcare workforce of 190,000, but the problem is a 10 to 13% churn in the system. We train people here, we get them to their first year, and they don't stay. And particularly with mental health, we get them to the point, 2 years of training, post-qualification, and they go into the private sector. And that is not helpful. We've got a large number of providers. That's about 500 different employers there we're looking at. So it's very difficult to have that consistency. And you have a clustering of these gaps. And the problem for us across the north, not just the northwest, is a significant amount of our workforce, and for me as a training workforce, they don't actually want to be here. They want to be here because A, they want to do a specialty that's easy to get into, perceived to be easy to get into, so they'll go for general practice, psychiatry, perhaps one of the others, but what they really want to be is a medic. And actually they've put us top because it's easier to get into the northwest, northeast, Yorkshire and Humber than it is London. And then you get somebody who may be on the cusp, who doesn't want to be here, is commuting at weekends and is social isolation. It's a catalogue for disaster. So again, we have to think of other ways. Is come to the northwest to train and learn, and we will look after you and you'll stay. I'm ex-army, and the army had a phrase: you recruit a soldier but you retain a family, and if you look after them as a whole package, they will stay within the team. And I think that's very relevant. So this is a piece of work done by Public Health, and it's looking at health inequalities. But if you map those 3 gaps I talked about earlier, you've got those same quality gaps. I've got 13 trusts in GMC enhanced monitoring in terms of training, which is the canary in the mine for quality of care. They're all in this sort of the northwest, within that sort of that footprint there. And then if you look where our workforce gaps are, it's that same footprint, and it's that sort of lethal triad. I like this slide. It describes the workforce challenges, and basically what it is describing is your classic wicked problem. And it is not enough to deal with it in a very reactive, linear fashion. So it's not as simple as saying we'll provide 5,000 more GPs. It's actually thinking about all the elements. So I like to think of this as a clump of frog spawn in the mire of a wicked problem. And what you're actually doing is you're managing all the elements of that wicked problem. You're never going to solve it, but at least if you try and manage it, it's really helpful. And just to focus on two elements that I think are really important, it is not as it was when I trained. So what we are recruiting people into is different from how it might look when they emerge at the other end. So if you want a healthcare workforce, you need to train them. They need a different skill set to do the job that's fit for purpose. They're working in a different way, and there are lots of new models of care which again require new skills. There is a growing demand of the service. I've seen this in general practice where particularly millennials who are expecting 24-hour culture, why can't they see their doctor anytime, any place, anywhere, in the same way that they can access all the other resources? And actually, why do I need to see the doctor if I've got an app that I can use on my preferred way of communicating with people? And again, changing perceptions. A lot of people still think of us, particularly in general practice, as we're delivering the Dr. Finlay model. And actually, we're not doing that anymore. We're delivering it much more in terms of the federated model from hubs across the spokes. It's a different way of working. So the priorities for us across the Northwest are to deliver on the 5-year forward view objectives. We've got to develop and underpin a workforce strategy. I'm not allowed to say future-proof, but actually I think that's really important, that we make that workforce strategy evidence-based, proactive, and we build into that some sustainability that gives it resilience. We're moving towards the multi-professionalism, so we're not just postgraduate medical and dentistry, we are training all the professionals for the future workforce. So for us as deans, I think the single biggest issue for us has been this, the fallout from the Bowagaba case. And it has created a climate of fear amongst our juniors around reflection. We've had the Sir Williams and Norman Williams report published with some recommendations, which I think has been really helpful, but it has focused on gross negligence manslaughter. But one of the things that I think has been really helpful in the report is the need to professionalise things like the role of medical experts, and actually improving the understanding in the coronal service and in the police about when there's a death around a medical death and when it's appropriate, the thresholds for gross negligence manslaughter. So I think there's a lot of good stuff coming out of that. But particularly important, we're not different because we're doctors, and it's not that we're above the law, but we may need to process that information in a better way. The message for me as a dean and for supporting our students is that we absolutely have to make the culture safe for them to say, actually, I know we're strapped in the service, but I've just come back from maternity leave. I can't do 12-hour shifts back to back. And that she's safe in reporting when there may be system errors. And that hasn't been the culture in the past. We're getting there. So particularly for us, what we're doing around reflection is we're moving away from this very sort of looking at the content of the reflection, to developing the reflective practitioner. And I think that's where, in developing our curricula and how we capture it in the portfolios, we need to change. Because we are processing our information in terms of, yes, we do want you to reflect on critical events, but it's the learning from them and how that changes your practice going forward and confirmation of your engagement in reflective practice that we need to put in the records. At the moment, the climate of fear is such that trainees are not engaging in reflection because they feel it will be used against them. So there's a lot of work going on there. Also a lot of work around the review of curricula. So what the GMC are doing at the moment is they're looking at all the specialty curricula and they're reviewing them around how they deliver the general professional competencies and around the issues and objectives around shape of training. So they are looking at making a much more generalist approach to the curricula. They are looking at widening access. So they're particularly wanting us to make it more open in recruitment. And that's not about dropping standard, it's about making specialty training pathways more accessible and being more flexible and alternative routes to certification. So that, for example, if you've been an SAS doctor and you have had relevant experience in 5 years, we have to make it a lot easier for you to get to your CSER and support. And actually you might be able to use that as an incentive of these new models of care to be able to support your medical workforce when you can't recruit enough people. We're looking at credentialing opportunities, and clearly we have to look at the issues around differential attainment, and I'm sure you'll see that in undergraduate exams as much as we see that in postgraduate exams. And this is just to list, there's an awful lot of work going on about how we can make our curricula and our pathways much more flexible, much more inclusive. We've had the draft healthcare and workforce strategy in England, which it's been really helpful and it's looking very much towards the future. 2027, that's what? That's 9 years ahead. Similar target areas. But what's different for us is, I'm afraid primary care trumps everything at the moment, but actually mental health has moved much higher up because we're equally strapped in mental health. And I think there is a focus on the urgent care pathway and the winter pressures issue. And again, this is not about throwing more emergency physicians into the mix, it's about looking at the whole problem. And it may be that actually you can ease the bottleneck by making sure that you've got primary care pathways. Why not have your GP doing triage in your emergency care pathway so that you haven't got these hordes of patients pitching up to A&E who don't need to be there? You've got a primary care clinician on site to triage it. So again, we just need to think a little differently. I won't dwell on this because we are running out of time, but Health Education England is engaged in a medical education reform programme. This is mainly around the issues that came out of the junior doctors contract. And particularly what they're wanting us to do is lighten the burden of assessment. So our main work stream has been around the ARCP review. And this just isn't just about the ARCP. It's about improving our processes of how we encourage trainees to prepare for revalidation, how we give our appraisal systems, make our appraisal systems much better, and how we make it less tick box and burden that and reduce that burden of assessment. But what's become evident is that we actually have an appraisal and assessment system that works very well. And are there best practice principles that might be applied across the wider workforce? So our colleagues in community pharmacy are really interested in a similar ARCP process for pharmacists, and we've worked very hard to get some of our clinical pharmacists prescribing rights and again working in primary care. The people who are really interested are the physicians associates, and I know you've got a good physicians associate cohort coming through. Well, we had the first cohort this year. And similarly, advanced clinical practitioners. So that leads us on to HEE's Blue Triangle, which is basically saying we need to extend the principles of good assessment across the wider workforce. And this is our tool for actually generating those conversations across the wider system. The Blue Triangle is about developing the multi-professional team and developing the concept of the modern firm. So gone are the days where you have the surgical firm, which is just your consultant, surgeon and his medical team. Actually, the way we work in teams, we have a whole multi-professional team working with us. And actually, do you need the doctor to lead handover? It might be that you've got your physician's associate who's been the one who's on the ground doing all the work. Maybe they lead handover for the team and you all feed back from the debriefing progress. So lots of work there. You can't see that, and I only put it up there as an example. I'm lead dean for psychiatry, and they came to Mental Health Programme Board with a list of all the new roles they're developing in mental health services, and I was completely blown away. Because actually, if you realise all these new roles, you may not need as many psychiatrists to deliver the service, which takes the pressure off there. So we come to HEE's Transformation Star. And this is just a tool to use, but what it does is it gives you an opportunity to open the dialogue and around how you might use these opportunities within the 5 pillars of the STAR to support you in delivering workforce transformation. And there is a web version of this, and I haven't been able to sort of load the link, but basically what it does, if you were to click on supply, and if your issue, say, is around primary care, this bit would whiz round to primary care, and then you could click in on all the resources, and it gives you all sorts of frameworks. So if you're actually in there and say, well, actually, okay, bit about supply, but how do I upskill some of the people working with me in primary care? And hey presto, you've got all the frameworks for all the advanced care practitioners, the PA roles in primary care, your primary care pharmacists, all in there. Absolutely fantastic. I'm sort of blown away by that. So those are just the pillars. And as I say, the Blue Triangle meets the STAR is a way for us, I think, to be much more proactive and evidence-based in your workforce planning. So we get the right balance in the multi-professional teams. And I just throw this to you as a challenge. Now bear in mind, I'm lead dean for psychiatry. I'm not a psychiatrist, I'm a GP. And I went to their conference and I challenged them to think about it. Because they do have a problem in psychiatry, and particularly in certain specialists, they are 30% under-recruited, both at consultant level and into the training pathway for child and adolescent psychiatrists. So, and there's no way we can grow enough in time. And I just challenge them, do you need to be a doctor to be a mental health specialist? We've got other areas where, for example, public health, you don't need to be a doctor to be a public health specialist. And I'll just illustrate what I mean about thinking differently and thinking outside of the box by a real life example. One of my trusts across Cheshire and Merseyside could not recruit enough consultant geriatricians. And what that had a knock-on effect in terms of training, because they didn't have enough people to supervise my trainees, because they were also strapped and work intensity service delivery. Of course, if I remove the trainees from the learning environment, that just makes the whole thing worse. And it was so bad that the geriatric service across that area of the patch was threatened with closure. And they looked at it really differently. So they had a chief registrar in to try and help manage this sort of intense workload. They invested heavily in physicians' associates and in advanced care practitioners to be able to support the workforce. And now they have, and they also supported their SAS doctors. So they made a real package of come to us for 2 years, we'll put you an education package that supports your CSER. They're in a position now where they're able to deliver that service with fewer doctors, but actually they can deliver on the objective. So much so that the stroke thrombolytic service threatened with closure is not going to close. And they're working more closely with their trust partners across the locality to make sure that the whole thing doesn't fold. The result is patients in that part of Merseyside get the standard they deserve and the quality of care. And that's what I mean about turning your head and thinking differently. So I'm almost on time. I'm going to leave it there.